All right. Well, good evening, everyone, and welcome to the third and final session of this year, or really 2020's Lumbar Spine Research Society's instructional course lectures. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure of moderating this final session with Mike Lee from the University of Chicago. We have an absolutely outstanding faculty that has agreed to kind of get together tonight and to kind of just chat about some cases. I really hope that this ends up being very interactive. I encourage the faculty to challenge each other, challenge us in terms of cases, thought processes, what you would do. And I would also obviously kind of welcome the attendees to do the same. Really, I'm sure many of us on this call do this at our institutions, but we do one of these conferences every Friday morning with our fellows. And it really ends up probably being one of the better educational experiences, at least from a learning standpoint. So a couple announcements before we start. This content, so this is the third session of the ICL. We started 2 weeks ago talking about perioperative optimization of adult spinal deformity patients. Last week, we had a great session on some of the surgical considerations, and then obviously we're tying it all together tonight with cases. All of this content is recorded. You can find it on the LSRS website. You can also find the annual meeting content on the website as well. So I encourage you all to kind of look at that if you're interested. A huge thanks to everyone who has tuned in over the past 3 weeks. The attendance has really been phenomenal. We've been averaging about 70 people for the live online sessions, which really is just fantastic. We realize that there's a lot of kind of stuff going on in the world right now. There's a lot of online educational content, and it really means the world to me, and I know everyone at the LSRS for you guys participating. So thanks again. And then finally, before we start, just a huge shout out to Katie, who really, none of this would happen without you, Katie. So thanks for everything you've done for this ICL. So just in the way of brief introductions, I'll kind of go left to right on the screen here. So we have Jeff Coe, who is the educational chair of LSRS this year. He was my co-chair last year, and really was a pleasure working with Jeff. So thanks, Jeff, for everything you did. Jeff is at Ortho North Cal in California. Next is Doug Orr, one of my partners who I've learned a lot from over the past 6 or 7 years. Doug does a lot of complex deformity at the clinic, and he tends to be very entertaining in these sessions as well. So I'm sure Doug's going to be really vocal. Next, Brandon Lawrence, one of my good buddies from the University of Utah. Brandon, thanks for participating in this. I think this will be fun. Next, Cliff Tribune, one of my mentors from the University of Wisconsin, who I think is driving across the country right now. No, Cliff, thanks for tuning in, and excited to kind of hear all your comments. Moving along.
It's my special moving background,
Next, we have Mike Lee, my kind of chair moderator for this session from the University of Chicago. Mike's put some great cases together that I think are going to generate a lot of discussion. And finally, last but certainly not least, my boss, Mike Steinmetz, who is the chair of neurosurgery at the Cleveland Clinic, and one of my closest friends and partners. And Mike just got out of the OR, so he's in his office. Anyway, so let's go ahead and get started, guys. Hopefully this will be fun and interactive. So in terms of this, so these are the panel. I showed this slide, I think, on the first talk and the first session 2 weeks ago. And I just want to put it up here again, because I think regardless if you like to do deformity surgery or not, I think really everyone obviously has to understand this, because a few people have said this before, but Doug has always said this. Every instrumented case is a deformity operation, right? You're either treating it, preventing it, or creating it. And I really do believe that. So the population is going to age quickly over the next 15, 20 years. A lot of these patients are going to develop these issues. And I think it's really important for us all to kind of talk about these things and gain a better understanding of how to treat them. And I learned this from Cliff a long time ago, but just because you have a curve doesn't mean you really need a big deformity correction operation. And that's really kind of I think the point of this session is just to kind of start talking about, what goes into the thought process of choosing what to do on these patients. Do you have to do something big? Can you do something smaller? And hopefully that'll kind of be hashed out in this session. So just in terms of some of the things, I think about when I evaluate these patients is obviously symptoms are incredibly important, right? What are they complaining of? Most of them are complaining of pain, right? They probably wouldn't see if they weren't having pain, but where's their pain? Are they having, a lot of neurologic symptoms? Are they having radiculopathy, neurogenic claudication? Are they having debilitating back pain because of postural issues? And how bad is their function? How bad is their disability? I think that really comes into play in terms of, deciding what to do on these complex patients. And then the last thing, at least from a symptom standpoint, I always think about, are they complaining about their posture? If they're not, I strongly try to figure out a way not to put them through a big deformity operation. But if they are complaining about their posture, I think obviously you have to pay attention to that. Obviously, global alignment comes into play. What are the goals of surgery? The health of the patient, and then obviously kind of our skill sets, I think all kind of come into play. So this is the first case. This is a 62-year-old female. She's a pretty active female. She and her husband like to travel. She used to be, relatively active and actually used to run and kind of be fairly athletic. She complains of back pain. She's got severe left leg pain. And I'll tell you, the left leg pain is basically in the L4 and L5 distributions, kind of buttock, posterior thigh, and then shin. So Brandon, why don't I start with you? Take me through kind of what you see on these x-rays. What are you kind of thinking? Obviously, what other studies you want, and we'll kind of go from there.
Yeah, I mean, it looks like probably the majority of her neurologic symptoms is coming from that fractional curve down below or at the lumbosacral junction. I like the way that her L5-S1 level is level to the floor. As soon as I kind of see that aspect of it, I start to think about these in a little bit of a different way. In that if I can stop at L5, I will. If I can avoid going to the pelvis, I will. And this may be one that I'm already intrigued in looking at, obviously full-length Scoli films, as well as, some advanced imaging to try to figure out if that's possible. But that's kind of like my first thought when I see this AP X-ray.
Perfect. Yeah, I love that. I remember, Cliff, I'm going to use a lot of things that you kind of told me a long time ago, but I remember one time you told me try to avoid fusing people to the sacrum like the plague, which is funny because a lot of us do a lot of fusions to the sacrum and pelvis, right, for various reasons. But I completely agree with you, Brandon. I think, looking at 5-1 and kind of, seeing if it's asymmetrically collapsed, do you need to do decompression there? Obviously, what their overall alignment is, I think all those things kind of come into play. So Doug, why don't we go to you now? So Doug, now these are her Scoli films, and I'm sorry if they don't project the lateral terribly well, but what are you kind of seeing?
So I'm seeing a couple. So the first thing I'm always looking at is balance. If somebody is balanced in both planes, my brain goes basically, I sort of divide these patients into, this is a patient with a deformity problem, or this is a patient with a degenerative problem who happens to have a deformity. And to me, if they're balanced, I'm already thinking, okay, this is somebody where the dominant problem is more likely the deformity or the degenerative stuff, and that the deformity is just sort of there. So I see that she's balanced. Looking at it, it looks to me, I see two sort of areas that concern me, given her symptomatology. One is looks to me like she's got a degenerative spondylolisthesis at 4-5. That lateral is not great, but it looks like she has one.
Yep, you are correct.
She's also got a rotatory subluxation lateral listhesis at 3-4. So to me, I'm thinking that this is probably a focal problem. I agree with Brandon. I love seeing a flat top of 5 because that tells me I can sort of take 5-1 out of the equation. And so I'm sort of looking at this and going, I think this is some combination of her 3-4 and her 4-5 leading to her symptoms.
Okay, good. Cliff, any other thoughts before we move on? Cliff's walking.
Hey, Jason, can I ask a question?
Please,
I want to see an MRI.
Yeah.
Hey, how convinced are you? Are you convinced completely that this is an L4 radiculopathy? It sounds, by dermatomes, but again, I don't know. This is someone I probably want to, obviously going to show the MRI, but someone I probably would do a selective block, at least in my practice, just to help kind of confirm that. I think it's pointing to that. That's where the pathology is at. I'm not denying that, but just, I don't know, just throwing that out to the group that I'd maybe get a selective block here as well.
Yeah, Mike, good point. Cliff, here's your MRI. These are kind of select cuts through your MRI. She's got that spondy at 4.5. She is, she's fairly tight at 3.4. She doesn't have kind of classic neurogenic claudication symptoms, but if you kind of ask her, she'll start telling you that, yeah, her legs feel a little heavy and tired when she tries to stand and walk for long periods. But it's really kind of her left leg pain and her back pain. And this is the interesting about this lady. And for the residents and fellows in the line, I'll tell you that the more you see these people in clinic, the more you're going to understand what their problem is and what you're going to offer them. So it really helps sometimes to see these folks, 1, 2, 3 times to kind of really get a better understanding of what really their problem is. So anyway, you could see here this big hypertrophic facet on the left at 4.5. Her L4 foramen is just kind of smashed there. Like Brandon was saying before, look at 5.1. 5 root is wide open, and there's no stenosis at all at 5.1. 2.3, there's some mild stenosis at that level, but no significant kind of compression. So with that said, I will tell you that I sent her for a block. I sent her for a left kind of L4 selected nerve root block. She did pretty well with that block for a few weeks with pretty significant relief of her pain and symptoms. So Mike Steinmetz, I'll stay with you for now. Well, what do you think, buddy? So you got this 62-year-old lady, he's got this curve. I think sometimes the easy answer is to say, okay, well, T10 to pelvis, right? But not everyone needs a T10 to pelvis. Probably try to avoid T10 to pelvises, right? And a lot of these people. So what do you think? What are the options?
Yeah, I mean, I agree with you. It's like Doug was saying, like, I don't think this lady's presenting with a radicular problem and not necessarily a large, scoliotic deformity problem. I think the challenge here, is, trying to add, it seems like she's got an L4 radiculopathy, right? So how do we address the L4 radiculopathy in this setting? And I think, again, she's got a degenerative scoliosis at 4.5. She's got an overgrown facet, and it's in sort of the concavity of that fractional curve. And I think the other problem is, you've got this lateral aesthesis of 3, so, I'm thinking like right off the bat, before we start going bigger, like maybe I'm thinking I'm going to do a single level, facetectomy infusion of 4.5, to decompress that root adequately. But then I worry because she's got this lateral aesthesis at 3.4, so now I'm thinking, and maybe there's some lateral recess stenosis there, still catching the 4 root, do I need to include that? And then, and then the apex of her curve looks to be the 2-3 disc. So, I'm factoring all of those things together, Jake. So I'm thinking what I would do is I don't think I could do just a foraminotomy there, 4.5, and adequately open that. So, I'd be thinking I'd want to try to take that facet off and fuse it, but not just fuse 4.5. I would probably, even go beyond 3, you know what I mean? And maybe even up to 2. To try to stabilize it. So that's kind of the thoughts going through my head is, how am I going to get that nerve decompressed adequately, and not cause her, further problems. I've done this in my hands now a number of times where I try to do a foraminotomy, not with a spondy, but in that fractional curve in the concavity of it, and just not able to open the foramen up enough at all, and just fail, without taking the facet off. So that again, I'm just thinking I want to take the facet off. I want to fuse it. I don't think I can just do it with 4.5 with that 3.4 slip. I probably want to go up to 3, and then I'm nervous about the apex there, and maybe go up, even one more level there, with the fusion.
Yeah, I think those are all good thoughts. Jeff Coe, what do you think? What would you do, or what would you consider? I guess I don't think there's a right answer here, obviously, but what are your thoughts?
Okay, so I agree with just about everything's been said so far. I mean, I suspect that she's entirely symptomatic from the foraminal stenosis at 4.5. The problem is she's got lateral aesthesis at 3.4, and then that severe degeneration at the concavity of that upper part at 2.3. The other point that hasn't been made is what part of her curve is structural and what is not. So you'd consider getting side bending films, perhaps. I don't often get them in adults deformity, but this is the case. I'd consider it to see how much this unbends. And I'm really interested in the left side bending to see, in theory, let's say that you fuse to 2. in theory, you're fusing to the middle of a curve, but if that's non-structural, you might be able to get away with that. And I certainly echo the thought about not going to the sacrum. In my practice, I really like the lateral approach. I really like doing anterior column support, have the heavy lifting of deformity correction. I'm a big believer in the concept of indirect decompression. It works fantastic for that. So you could approach 4-5 either with a T-lift or with a lateral approach, O-lift, D-lift, X-lift, whatever your choice is, depending upon the psoas and lumbar plexus anatomy. And the same thing at 3-4 and 2-3 if you wanted to use MIS techniques, which is probably how I would approach it. But if that upper curve unbent, and I was convinced that the real structural curve was that lumbosacral fractional curve, I think that probably 3-level surgery would work, and even without a direct decompression, because I think you'll decompress the foramen with your inner body. If you want to do a direct decompression, that level probably would be best treated with a T-lift. And of course, you have the option of not doing inner body fusions at 2-3 and 3-4. But I'd be tempted perhaps just to do a single level procedure at 4-5, but I'm concerned that would break down pretty quickly, and she's heading for more surgery. So I think maybe a 2 or 3 level, but probably a 3 level from 2 to the L5 would work. I try to avoid 1-2 because you're rapidly, then you're starting to go up to the T10 level there. So.
Hey Jeff, I didn't look at her MRI for the psoas, but you're right. If you look the anatomy of those 3 discs, to get them in a relatively straightforward lateral approach, it sets it up fairly nicely.
Yeah, I've been doing lateral since 2005, and I just really love it for adult deformity. And then it allows me to do percutaneous posterior procedures a lot more readily. And that's not always an option, but if I can do it, it's a big win. It's been a big win for over a decade in my practice.
Yeah, Jeff, I think those are really good points. And I am, in full disclosure, not a lateral guy, although I've been doing more probably in the past 3 months than I ever thought I would, because I am kind of.
So you are capable of learning.
Yeah, I've done 4. I do agree that, and I'll show you what I did in a second here, but which is not lateral, but this is a good one I think to consider. Doing a lateral, because you can get to every disc easily, probably, right? 2, 3, 4, 4, 5. But anyway, so Cliff, go ahead, Doug.
I'm not so worried about 2-3. I think if you can level off 4-5, reduce this rotatory subluxation at 3-4, 2-3 will correct enough that, yeah, maybe 5-10 years down the line you have to think about it. But I think for now, I'm not so concerned about 2-3 because it doesn't look to me to be unstable. There isn't a rotatory subluxation. It doesn't match with the symptoms. There isn't an anterolisthesis. Another option that wasn't put out there, but I noticed Jason very carefully cropped it so you couldn't see the vessels very well. But this is one where I would strongly consider doing a 3-4-4-5 A-lift and perk screws. It accomplishes everything that the other does. Is there a huge advantage of it over a lateral? No, because I'm one of the idiots who still does his own approaches. I'm still happy doing it, and I think that this would be a good case to do an A-lift.
Cliff, final thoughts before I show you what I did, and you guys can critique me.
The most I would do would be a 3 to 5 A-lift with perk screws. With a lateral prosthesis going off that way at 62 years young, you've got 8-10 years conservatively to fix whatever problem you don't address right now. I would go after the symptomatic area, probably just do a front A-lift at 4-5 and perk screws at 4-5. Because she's lateralisthesed on the concave side. I think this is like, so where else could that L4 be picked up? She wasn't that stenotic at 3-4. I'd probably leave with a buffer. I definitely wouldn't do 2-3, and even 3-4 to be somewhat debatable. The idea that we're all trained on of don't stop your fusion at the apex of the curve, and lateralisthesis is the worst thing since ever. I actually, for a first pass in, when I'm going after just symptomatic stuff, I actually will somewhat downplay.
So one other thing, I really talk to the patient and ask them what are their thoughts, because with MIS surgery, Cliff's 100% right. You could do if the patient understands that the recovery from an MIS approach, an MIS TLIF, let's say, or a lateral, or even an ALIF, is rapid enough. It's different than when I trained in the 80s. And the big, you can get away with doing a small procedure, and if the patient's open to the concept, and you have to tell all your patients, you can never guarantee that any operation you do is going to be the last spine operation they have. Patients ask me all that time, well, Dr. Coe, I want this to be the last spine operation I'm ever going to have. I says, well, that's not going to happen unless you die on the table or something like that. So the comment to Cliff's suggestion of avoiding 2-3, you can't demonstrate instability statically, but if you see, if that concave side that's totally collapsed opens up on a side bending film, that level's in trouble, and you'd want to do it sooner rather than later. If it doesn't, then maybe a 2 or even a 1 level fusion will work. So, and again, an ALIF is an excellent option. Whatever you're comfortable with doing. I'm blessed to have a fantastic approach surgeon. So I'm very comfortable with ALIFs. I don't do my own approaches. It's, I don't want to get into a vessel trouble and not be able to handle it with the approach surgeon there, then they're invested. So.
Yeah, guys, I think that was a great discussion. I chose this case to hopefully get that conversation, because I don't, I struggle with this, and I tell the residents and fellows all the time, I promise you the surgery part is going to be the relatively easy part. It's deciding what to do is the really hard part, right? And you just heard 6 really, really good, really thoughtful surgeons kind of talk a little bit differently about this case. I'll show you what I did, and well, actually, before I show you what I did, I'll show you what I did, and then I'll tell you why I did it. So I ended up doing 2 to 5. And so I saw her several times in the office, and her left leg pain was always the primary concern. She was kind of a little concerned about her kind of posture and kind of her like trunk kind of like, translating a bit, but it was more her left leg. But then she kind of started talking about both of her legs and kind of heavy and tired. So it started getting me to 3-4. So then I said, okay. Because when I initially saw her, I was thinking 4-5 TLIF. Do a 4-5 TLIF, decompress that root, and be done with it. And then I said, okay, I'm going to do 3 to 5, because I was a little worried about not decompressing 3-4 and her still having kind of some of the neurogenic claudication symptoms. And then this is where I'm not sure if I did the right thing or not. I kind of said, wow, I don't really like how 2-3 is so asymmetrically collapsed, and it kind of did, at least in my mind, started to kind of rotate. So I ended up going to 2. I did an asymmetric TLIF at 4-5. So these are her films. That's kind of her pre-op and post-op. She's doing well. That she's probably 3 months now. So, I mean, it's obviously, who knows, right? And I agree with Jeff. The only thing you can guarantee these patients is that they will have another surgery at some point, right? But her left leg pain's gone. She is doing fairly well. I think she made me sick.
Jason, do any antibody at 2-3?
I didn't. And so that's what I wanted to ask you guys now. So, Cliff, since you mentioned that, would you have interbodied at every level? I tend to not interbody every level that I.
Well, it looks like you did it. Your rods look like perk rods. Was this done posteriorly?
No, it's all posterior. I actually ended up more to kind of teach the fellows a little bit. I put reduction screws on kind of this right side and kind of just showed them how to kind of like, use the reduction screws and the rod to kind of translate. Not that this really needed that, as you know, but just from an educational standpoint. But no, this is an open kind of system.
Hey, James,
you essentially did a deformity operation, which looks wonderful, and if 1-2 holds that, you got a huge win.
Yeah.
So it's just a question: too much, too little. Who knows? It doesn't look too little to me. I can tell you that. And if that holds, you don't have a deformity per se anymore. Really, you got a little bit of stress on 1-2, but. Not unreasonable. I guess to answer your question, would I have tried to do an antibody if I was going 2 to 5? I probably would have tried it, because you probably could have leveled that disc off that much more.
Yeah.
And then you could have perked her posteriorly.
Yeah.
So a 3-level anterior. With COVID, our hospital got shut down in terms of elective cases that I could bring in staying overnight. So I actually started doing ALIFs with perk screws 1 and 2 levels outpatients. And not everyone I had signed up did it that way, but I postponed about half of them. But did one today, and I got another one tomorrow. So they're very doable. It's a much different operation, to Jeff's point, than it was previously.
Another thing to consider in this, when you're not trying to decide what to do with 2-3, one of the advantages with the ALIF or the one of the lateral or OLIF approaches is you can do your 4-5 and 3-4 and get an AP X-ray and take a look. And very often, if you've corrected 4-5 and 3-4 well, the 2-3 doesn't look so bad, and so you may be able to save a level by doing that. But I think the result you got here is great. When we're offline and I'm abusing you like I usually do, I'll slag you for about 7 things. But no, overall you've done good.
Hey, Jason, we have a question from an audience member.
Mike, go ahead, Mike, yeah.
So there's a question about stopping the construct at L2-3 or L3-4 near the apex of the curve. One of our panelists comment on when they feel that it's safe to do that, or is it just a correction of the deformity that was anticipated so that the curve would be much more or less? Can you start off commenting on that, Jason?
Yeah, Mike, that's a good question. I don't know if I have the right answer, but my kind of thought here, and some of the the panel have mentioned this. My thought was if I can kind of get 4-5 to kind of be horizontal, and then kind of reduce the rotatory sublux at 3-4, and obviously I decided to go up to 2 to kind of pull that over. I thought above that would kind of basically straighten out. I think that's kind of a little bit of a compensatory part of this curve. Jeff brought up a good point. I don't do a lot of bending films in the adult world. In the idiopathic world, I do a little bit, but in the adult world, I don't. But I think it's a very reasonable option to kind of see kind of how flexible that's going to be. They tend to be pretty flexible. Kind of above these kind of lower lumbar kind of fractional curves. But Brandon, final thoughts on this? What would you have done? Honestly, would you have done this? Would you have done a 1-level TLIF or
Jason,
laterals? I think laterals are a decent, really good option. I'm just
Jason,
my hand sounds good, but
Jason, let me interject 1 second, because
yeah,
it really is. We really are dealing with unknowns. So what we're really talking about is trying to avoid the next operation. Okay, so, and I can't convince myself that getting around the corner, if you will, in a deformity like this versus just treating your stenotic area is going to reduce that. Because if you get around the corner, now you got a longer lever arm, right? If you stay below the corner, now you're below that apex of deformity. 6-1, half dozen other to me. So to me, that's where I fall on the side of trying to do that smaller operation.
Yeah. I think to your point, Cliff, I think there's a big difference in this patient if they were asymmetrically collapsed at 5-1 and you were having to do 5-1. I think it's very different coming up from the sacrum and stopping at an apex than it is floating something above a mobile 5-1. Yeah. I think that I'm much more confident in stopping. At this one, I probably would have just gone 3-4 and 4-5. Yeah. I'm much more confident in saying that and not worrying about the apex if it's a floating fusion than if I've started at S1. Then I think you do need to round the corner.
Yeah. Well, the question when you go to 1, it's very rare to see stenosis at 5-1 that you have to address. Yeah. So you could almost make the argument anyway, stop at 5 regardless of what this looks like.
Yeah. So, no, I agree.
So if you're truly doing a stenosis operation in the setting of a curve.
Yeah, I agree.
Hey guys, don't you think though in this, I know we've been talking about this limited fusion, but there was some talk about maybe just doing 4-5 and when we look back at her MRI, she doesn't have a lot of stenosis, but she's got some lateral recess stenosis. Do you think that lateral, I don't know, in some of the patients I've done, I see with that lateral aesthesis, and it's a foreradicular problem in the foramen, but they often are, in my view, or at least what I'm thinking, still catching the foreroot in the lateral recess, the level above. I mean, do you think we can add in this patient in particular, just a 4-5 would do that, or just if we just try to limit it, maybe a 3-4, 4-5?
I'd have trouble doing a 4-5 alone with that degree of lateral aesthesis at 3-4. I'd be much happier including 3-4.
In my mind, to your point, Mike, I was less concerned about the lateral aesthesis and more concerned about that 4 nerve root.
Gotcha.
Yeah. So I probably would have talked myself into a 3-5.
Okay.
Brandon, final thoughts. What do you think? You started this off well.
Yeah.
What do you think?
I mean, I would have done the exact same thing, to be honest. I probably would have done just try to get more surface area at the 4-5 for the inner body, and would have done, a traditional banana shaped TLIF. but I would have done the exact same thing. I would have done 2 to 5. I would not have felt comfortable leaving 3-4 alone. I think you can level off and start to derotate that 2-3 level and fix that asymmetric collapse. I would have done the same exact thing. I'm not a perk guy for deformity. I feel like I have enough trouble getting these to fuse open, and so I'm not a perk guy for deformity. So I would have done the exact same thing.
Awesome, guys. That was a great discussion. Let's move on to the next case. So Mike, I'm gonna turn it over to you.
He was a plant. He was a plant.
So this is a 64-year-old lady. She comes in with back and leg pain, more anterior thigh pain bilaterally. For the sake of this discussion, let's assume she's undergone all the non-operative treatment therapy. Injections did give her transient relief, but not long lasting. She has that fusion constant there 3-4, which was done 3 years ago, but she's also status post now 4-5 posterior lateral fusion without interbody 6 years ago, otherwise healthy. So these are her films here. Jeff Coe, do you want to start us off and kind of lead us in your thought process and what you're thinking as you approach something like this?
Okay, so this is an example of a surgeon-created deformity. I mean, she's kyphotic actually at 4-5, really kyphotic at 4-5. There's very little lordosis, if any, at 3-4. And it's a little bit of spondy at 2-3. She's got a totally degenerated 5-1 disc. And so this is, I'm looking at this, and I obviously want to get the long films and look at the pelvic incidence, as well as the lumbar lordosis. It looks like she's compensated somewhat. I don't see her hips, but I'm inferring that she's probably got pretty good pelvic tilt going on. So I think this is a compensated patient with a significant flat back, if you will. I'm the old term for lumbar kyphosis. It's still valid today. So that's what I'm thinking about how I'm going to address this. Typically, in an ideal world, you want to address the deformity correction, if you will, at the lowest part of the lumbar spine, with 75% of lumbar lordosis being at 4-5 and 5-1. So, the thought process, well, can I do a hyperlordotic ALIF? I really like that, possibly combined with, type 1 or type 2 osteotomies posteriorly to get the correction where I can get it at L5S1. So that's sort of what I'm thinking. Obviously, we need the advanced imaging to see exactly where her stenosis is. She's probably stenotic at 2-3 by inference, but you don't know that she's not stenotic at 5-1 as well. That's a adjacent segment disease, possibly at both levels. So long films, advanced imaging, and obviously you want to go through the standard non-operative care. You might need various kinds of epidurals and perhaps targeted blocks, but that's my thought process in the workup.
Fair enough. Jason, can you advance the slide? And so these are her advanced images. She does indeed have stenosis at L2-3, pretty wide open down below at 5-1. And remember, 4-5 is fused, though it's fused posterolaterally only. And then the next slide, Jason, for the long films is Jeff requested.
Is 4-5 actually fused?
Yeah, it is posterolaterally fused.
You did a CT because I look at one like this when I see a disc that looked like that one did up front, and I always want to know, did they really fuse posteriorly? Because if you do, that's a place you can get a fair bit of correction.
Yeah, and that also affects how our surgical approach, I think. So yeah. There is a CT done, but it's not included in this presentation.
Okay.
She is solidly fused from 3 to 5 with what you see there. Yeah, exactly. So Brandon, here are the full length films. You can see that her pelvic incidence is roughly 37 degrees. I'm sorry, her pelvic incidence is 67 degrees, and her S1 to L1 is roughly about 37 degrees, so about a mismatch of 30 degrees. But overall, it looks like she's pretty well balanced. So what are you thinking now in terms of surgical strategy? How you want to approach this patient?
Who's up?
I saw her MRI briefly. Is she focally stenotic at 2-3?
Just 2-3.
1-2. That 1-2 level looks okay.
Pretty wide open there, yeah.
Okay. This is an interesting. This is a great case. You've got that lordosis at the thoracolumbar junction. you've got a pretty significant mismatch. Her looks like her tilt is super high as well. So even though she's well balanced on her on that at that moment that she took that scoliosis film, she's really compensating significantly for that lower deformity through her thoracolumbar junction as well as with her retroverted pelvis. So even though this is a focal problem at 2-3 above her prior fusion, I would be very cautious to approach this as just a single level adjacent segment disease problem, because this is one of those cases that will just continue to
On you.
allow you to have these boat payments because you'll just march up her spine. So I think with her fusion at 4.5, her open disc space at 5.1, I think it was Doug who mentioned the hyperlordotic ALIF. I love that, or maybe it was Jeff Coe. I do that quite a bit too, and it's a very powerful way to change that pelvic tilt, which is traditionally very difficult to change, but with these hyperlordotic ALIFs, I think you can. And we just got a sneak peek of what happened.
Ooh. Sorry, that was my fault. Sorry, guys.
And I would probably just go up to the level above, and I bet if you can get a significant amount of lordosis down below 25 to 30 degrees through that hyperlordotic ALIF, you're going to be pretty happy with just going one level up to L2.
Sorry about that, guys. I was answering questions in the chat. I accidentally hit that, so I apologize.
What are your thoughts? How much correction do you think you can get through that L5S1 level with an anterior approach?
Well, I hate PJK. So the question to me is, can you do a PSO at 4, a TLIF at 2.3, and keep this thing 2 to 5, and just float your fusion? Because you're certainly going to reduce your PJK problem. Because if you stop at 2 and you fuse to S1, you better get good correction. I love hyperlordotic cages, but I'm not mandated in my mind's eye yet to go to the sacrum here. It's a little bit more degenerative. I was kind of bummed to see that MRI, so I probably would, but in a form like this, I'd certainly float the idea of a 2 to 5 with a PSO in the middle at 4.
If you do a PSO, how much fixation above and below a PSO do you think is adequate to provide?
Well, I would do it at 4 because I'm floating that. So, and I think I'd be comfortable at the with the 5 screw below and a TLIF at 2.3, because you've got an anterior column at 3.4 that is solid, so you're just closing that column down. So and your disc has been ablated already, so I'd be hopeful you could do that. It's an aggressive move, I get it, and the contrary is to put your lordotic cage in first at 5.1, see how much correction you get, see if you need anything else other than just a posterior based osteotomy. I still would stop at 2 though. I wouldn't go above 2.
You know, a lot of deformity guys talk about the harmonious restoration of lordosis, with the apex of lordosis being at L4 or L3, or typically L4. Is in someone who's got a prior fusion, is the goal to just get proper balance metrics, or is it, how important is it to achieve that harmonious curve with the apex of lordosis being roughly at L4? Doug, you want to comment on that, or?
Sure. Ask me that question in 20 years. We just don't know for sure. I think there's a lot to be said for it. You know, it's funny. I look at this, and I'm old enough to remember Art Steffi talking at meetings in the early 90s, saying if you do a fusion and the top of L4 isn't parallel to the floor, you're going to be back. And you know, I look at all the stuff that people have done with angles and harmonious stuff, and basically it all comes down to, if the top of L4 isn't parallel to the floor, you've got a problem. You know, this one, I think a hyperlordotic ALIF at 5.1, and then, you know, at 2.3 you want to catch a little more lordosis at 2.3, and you know, the combination of a Schwab 2 and a TLIF at 2.3, I think between those you can get really nice alignment between those two interbodies here. I certainly would try not to go above 2. And this is one where intraoperatively, I would look at how much I got from 5.1, and then maybe a posterior column at 5.1. And then with that spondylolisthesis at 2.3, I think you're going to be doing it anyway. So I think I would probably T-lift 2-3 and get everything I could there. And I think that's probably going to get what I need.
Hey guys, how about look, we've been doing here at least many more laterals in cases of adjacent segment problem. How about a hyperlordotic cage at 5-1 and an expandable lordotic cage at 2-3, and even think about doing, depending on the anatomy, an anterior column release there, trying to get as much opening as you can at 2-3, from a lateral standpoint.
I agree with that. I think that's a reasonable option. I really want to focus on the 5-1 and get what I can there, and then do an ACR if necessary rather than a PSO. I like the idea, if you're going to do a PSO, to do it at 4, because when you get non-unions with PSOs, it's usually the cephalad level. So you already have a solid fusion there. And it's also best to do the PSO as low as possible for that harmonious correction. But certainly this is a case that I have similar cases that I've done the ACR type procedure at L2-3, but I want to caution those that are in attendance that if you don't have a lot of experience with doing lateral surgery, the ACR should not be your first operation. You are intentionally taking down the anterior column ligament for deformity correction, and it's probably one of the most vascularly dangerous MIS surgeries you can do, potentially.
Hey, Jeff, Mike, if you don't mind, I have a question for you, Jeff, just because I'm curious. Would you consider just doing a standalone at 2-3, kind of, with a, quote unquote hyperlordotic cage? I probably wouldn't do this, but I'm just wondering, because I think you do a lot more laterals than I do. Indirectly decompress the stenosis at 2-3 with that lateral, get some alignment, and avoid, a really big operation in this lady, and kind of just see what happens. I mean, is that kind of crazy, or is that a reasonable?
Well, that's an excellent question. Only to point out that if you release the anterior longitudinal ligament, if you actually truly doing it, it's a complete release. That's highly unstable. And this was really developed by Beruzak Barnia, and it is ill. Even if you put on a plate, it's just simply not enough. It's highly unstable. You have to have posterior fixation. So if you were able to put in a hyperlordotic cage and get it really tall, that you don't do a complete release of the ALL, you might be able to avoid posterior fixation. But I don't think this patient's going to be happy with just that. I think there's the patient, whether she realizes it or not, is tilting a lot because she's compensating. She's making her stenosis worse because she's extending her spine above your fusion at 3-4 and 4-5. So it's tempting to do that, but it's something that I would avoid. I don't think it's going to work.
How much fixation would you add, Jeff? If you did an ACR at 2-3, got good 30 degrees of correction, how many levels up would you go with your?
I think because you have the anterior, the whole thing is to get the tension band in the back. I don't ever do an ACR without a single screw in the integrated cage, and I think. Nowadays we're putting in 2 because I think you can get that posterior correction. You would need to do a Schwab 2 osteotomy or a Smith-Peterson osteotomy in the back as well. So I think a single level would work. So you can stop at 2, but it's because you got 3 column support, then you don't really need to go in this circumstance too high. It's a little bit different scenario than I think a PSO. You may need to go an extra level or so.
Okay.
I'm just concerned with doing, the idea of trying to do this with 2-3 alone with something hyperlordotic. I mean, you've still got your center of rotation is so anterior that I still think you need to do something to bring your things back. And so I think without addressing 5-1 and getting more lordosis at 5-1, I think at 2-3, trying to, even if you got wonderful correction at 2-3, I think you're still going to end up with troubles going down the line just because everything is too anterior.
No, I think we're saying that, Doug, right? I think we're saying still do 5-1.
Yeah.
But
Okay.
then do an ACR at 2-3 and get, instead of doing a PSO, use that as your
Yeah.
correcting nerve. Yeah.
Yep.
Mike, should we show him what he did?
Let's show them.
All right, sorry, I gave you a sneak preview.
All right, so she underwent a L2 PSO, extension fusion, 3 points or 6 points of fixation above, and I did take her down to crest or iliac as well. That's kind of like a pseudo quad rod construct. Usually, you do the stacked rods, L1 to L3, or one above, one below is a short rod, and then a longer rod kind of going posteriorly. It didn't quite allow for it.
So Mike, what do you have at 5'1", Mike? Do you have antibody or
No, I just relied on the iliac fixation. So that disc is pretty degenerated. So to me, it doesn't look like it's very mobile. So I just crossed the posterolateral, but used the relied on the iliac fixation to back up his S1 screws. And I think the next slide shows the correction.
corrected beautifully?
Yeah, it's very nice.
Yeah, I just wonder about the if it's too aggressive, and also the apex of lumbar lordosis not being at L4, being at L2. That is going to make a difference in the long run. And Doug, I agree with you. I don't know the answer, but I do think that her deformity before was predisposing her to having additional adjacent segment pathology year after year, or a few years after a few years. So hopefully this will stop her. She's about 4 years out and she hasn't shown up yet with any PJK, but I suppose it's still early. So
Cliff made a comment earlier, which you want to try to avoid that next operation. It's just a question of trying to put it off as long as possible and keeping in mind what that next operation might be. And I think what you've done is this may be your last operation, because it looks like you've got a really nice harmonious situation at the lower thoracic spine, and she's it looks very natural, and I think you did a very nice job.
Well, if you're 4 years out without PJK, it's a huge win.
Yeah, I agree.
still early though. Who knows what will happen in the future? There's a comment about possible overcorrection, and I think that's a valid point. Is that we used to think it used to be a perfect match, LL versus PI, and now we're thinking maybe 10 degrees. Now we're thinking maybe 15, 20 degrees, depending on age adjustment. And I do think that is a moving target. I think that's a fluid metric that really depends on a host of factors, including age. Yeah, it's a good point from Dr. Pauly.
Yeah, Mike, this looks great. I get worried, and I've had a couple of patients like this. The one thing that worries me a little bit, and obviously not being critical, but is when kind of like T10 and T11 are kind of approaching behind the sacrum. I get a little worried that there's going to be just a lot of stress kind of up above that. But like Cliff said, 4 years out, no PJK. This I think it's fantastic.
That's a win.
Yeah, and any deformity operation that you're 4 years out without PJK, don't care what you did, you won.
Yep.
Any other comments on this case or critiques?
Nope.
Jason, you want to move on to the next case?
There we go. All right. Well, we'll try to go through this. Actually, try to go through this pretty quickly because we have two cases. But so this is a 79-year-old. So 79-year-old, severe back pain, basically inability to stand upright. These are her Scoliosis films. Brandon, what do you think?
Boy.
That's right.
Agreed.
And no prior surgery.
She had a multi-level lumbar laminectomy. I forget exactly where. Let me see. I think this is her CT here.
Oh, yeah.
So here's her CT. She had a lammy, I think from L3 kind of down, and she's 79. She's a healthy 79-year-old. She's pretty miserable. For the sake of this conversation, we'll kind of assume that she, basically failed non-operative care. She's miserable. She kind of wants something done. She understands kind of that this is going to be a big deal. She had her DEXA scan. Her bone health was optimized. Kind of all that good stuff. So, I wanted to show this case because. Go ahead.
Yeah, just go back to that CT real quick. I'm just trying. It looks like the only open disc. It looks like 4-5, 5-1, and then 3-4 is fused.
Yeah.
2-3 probably isn't moving much, but 1-2 it's got a lot of motion.
Yeah.
These are these cases where it sure would be nice to be able to do a lot of the minimally invasive techniques that everyone on this panel is talking about, but in patients that are 79 and trying to rely on interbody support up front, just as it's just such a challenge. With that said, I think I try to get as much done as I can to see if I can get some sort of semblance of correction without having to do a T3 to the pelvis.
Mhm.
Does she look, what does her sagittal profile look on that CT again? Let me see that one more time. I just want to see if she's flexible.
She definitely
Yeah, so
moves through 1-2. You know, she definitely moves through 1-2. And I'm sorry I don't have the scout CT because I think that's a really
That's
good.
okay.
That oftentimes really helps kind of get a sense. But she's relatively mobile, but she's going to need a little bit more work.
Yeah, and again, I don't love relying on the interbody spaces or end plates to try to get any sort of correction at all. You know, this is one where even though you hate to do a PSO in an old person, this is one where I may try to do a PSO through that L4 level, just to try to get some restoration of lordosis down low, and then just extend her to maybe T12 and go down to the pelvis. I'd probably use cannulated fenestrated screws in this particular situation. Yeah, I think I'd be moving in that direction as long as she was healthy enough to tolerate it.
Yeah. Okay. Cliff, what do you think, Cliff? I think those are all great points, Brandon. I struggle with this.
A couple of things. I mean, number one, 79 is, unless she had parents living into her 90s, we're really pushing the limit here. In fact, that is the age. During my fellowship, Bradford did a 79-year-old. I couldn't believe it. He had, and both parents 96 and 97 years old. So this lady was looking at 16, 17 years of life. So I wouldn't quibble. I wouldn't criticize an operative answer here, but boy, I'd be scarily hesitant.
Mm-hmm.
This lady will, the question I want to ask her is, when's the last time she stood up straight? Because I bet you it was within the last year or two.
Mm-hmm.
This lady on the table will flatten out almost perfectly. You can probably manipulate a little bit. I don't think you're going to need a PSO with her at all. She's almost got a Charcot joint there. The question will be, once you correct her, she's going to open wide open at that 1-2 level. Then the question will be, do you need to sneak something in there anteriorly or just go high enough posterior to support her? I like doing 5-1 anteriorly. I don't know if I do that in a 79-year-old. I don't know that I pull the trigger on this person at that age, frankly, but I do. I don't think you need a PSO on her. I think she would flatten out pretty nicely. And then there's the question of how quickly you can get some screws in her and hold her there.
Cliff, if you don't mind, talk to me real quick. How do you pick your UIV in someone like this? Because I think that's something that I have.
Or above that osteotomy site, basically.
Okay. So you would not go in the upper thoracic spine. You'd probably go to like T10.
No, and she doesn't have a deformity up there. This lady failed above her previous fusion, probably fairly acutely. And you lay her on a table with a big chest roll. I actually will take a person's pelvis and manipulate them. I don't know if I did that while you're here. I mean, and I'll crank them back with just basically crack them back and have them, particularly with coronal deformities, if they fall off to the side, because our instrumentation is too powerful to, I mean, it's just, you can't bring them back with just instrumentation. So I will manipulate people on the table. I'll do the A-lift 4-to-1 and then manipulate them on the table.
Okay.
So I guess if I really said I'm going to do this operation, I'd go anteriorly 4-to-1, flipper, manipulator, not prep and draper until I had her right where I wanted her, and just go like hell to expose her and get the screws and try to get out of there in 3 or 4 hours like that.
Okay. For the sake of time, I'm going to show you guys what I did, and then we could talk through it. So, you know, yeah, these are, I was not excited to operate on this lady, obviously. You know, she was a, you know, healthy kind of seemed to be very motivated, kind of spunky sort of, you know, 79-year-old woman. Who I didn't ask her how long her parents lived, but that's a good point, Cliff. But anyway, I mean, she's got this deformity. I agree with you. I thought this was going to be relatively flexible through that kind of just crapped out disc at 1-2. But I ended up doing so. You know, I don't do a ton of kind of, you know, right off the bat T4 to pelvises. but I was worried about her, what was going to happen kind of above this when I corrected her, mostly because of kind of just how straight this thoracic spine was, and kind of looking at the proximal junction angle if I stopped at T10, and I don't know the right answer, but anyway.
No, it looks great. It looks great.
But I went up to her, but I agree with you, Cliff. She basically corrected on the table with a chest kind of roll up high. I think I ended up doing a PCO at that one level, just a facet resection at 1-2. I didn't put anything in the nearby space.
SPL.
What SPL? Yeah, SPL. Yeah, PCO. Yeah. And then and one thing I didn't do, which I'm a little surprised. It's funny, when I went back and was looking at this case to put in the talk, I'm a little surprised I didn't put a third rod across that kind of site, because typically I would do that, just kind of span a rod from about T10 down to the bottom, because if she's going to fail, she's probably going to fail right there, right? Because I didn't put any anterior column support there at 1-2, but
Nope. So at one like this with the PCO, what I really look at in terms of anterior column support, if you get corner to corner contact on that posterior corner, you've got anterior column support. If there's a gap there, you don't have anterior column support. But if the two posterior corners are touching, you've got some anterior column support.
Yeah.
I agree with Cliff. I would want to have had a little better look with the calcification she had in her vessels. I would have had a little better look at her vessels. I would have at least done a 5-1 ALIF and tried to do a 4-5. And I probably would have gone shorter. But it's one of those ones I tell these patients when I'm counseling them about surgery, that essentially this is a make it up as I go along operation. I know where I need to end up. I know what the tools I have to get me there. I don't know what it's going to take. I don't know how much she's going to correct on the table. So I'm going to do my ALIF 4-5, 5-1, or just 5-1. Then I'm going to flip her over, and you basically add on the building blocks till you got the result you want, and then you stop there. And you got to be flexible with these, because every one of them is going to be a little bit different.
Yeah, Doug, I think those are good points. I've gone to putting downgoing hooks at the top. Actually, the T4 to pelvis I did today, I went downgoing hooks at the top and actually upgoing pedicle hooks at 5 to kind of try to soften the landing and prevent these kind of proximal junctional failures. I also use a tether in her, which I don't use crosslinks a lot, but you see this crosslink here, so I tethered a Merceling tape. Who knows? She's about a year out. She's actually done really well. It was crazy. She
Again, you got to win.
Yeah, she left the hospital like on day 3.
PJ Cage, you've got to win.
Hey, so Jay, she did fuse across that one, because even at a year, sometimes they're not, you still have enough stability in the rod, right? And she's still not fused. Did she fuse across that 1-2 disc? Because I would be, again, as you mentioned, I think if she's going to fail, she's going to be at proximal junctional, screw back out, fracture, or at 1-2 with the rods breaking.
Yeah, Mike, that's a good question. She hasn't failed yet. I don't routinely CT these people unless there's a reason to. So I don't know the answer to that. I'll let you know. Actually, I'll just send her to you when she does break.
Yeah. We operate on the same day. I'll just be looking out.
Who are we kidding, Jason? You'll send it to me.
That's right. All right, guys. Let's Mike's got one more case. Mike, let's do this relatively quickly. If any of the faculty have a hard stop at 9, I totally understand if you need to get off, but we'll go for about 10 more minutes.
I've still got wine left
to discuss. So go ahead, Mike.
All right, sure. So this is a nurse and a ballet instructor who's had back pain for most of her life, about 2 to 3 out of 10. But what's really bothering her is an 8-month history of left lateral high, lateral lower leg pain. Really has to prevent her from doing ballet, which is really her passion in life. Treated non-op. The ESI gave relief, but it was transient. She's otherwise neurointact. She's here for second opinion. If the recommendation is surgery, she wants the least amount of surgery possible. Mike Steinmetz, what do you think?
Well, I mean, I think one is, so she's got probably going on a grade 3 spondy at 5-1, fairly significant degree of lumbar lordosis above that. Is her, just for the sake of time, is she fairly well matched between her sacrum and her lumbar spine with regards to angles, or she? Yeah. Okay.
She's this is largely a grade 2, grade 3 slip kind of a case.
And so, she's probably got radicular pain from the slip and foraminal stenosis, although I would want to be sure with the lateral thigh lateral lower leg, that is, indeed causing the pain. Oh, you said near complete relief. So that was 5-1.
Correct, at the foramen.
Gotcha. Yeah. So, I mean, is she, what about a MRI, just to look at that?
Oh yeah, next slide, Jason. These are flexion extensions, so it looks like it moves maybe a little bit. Certainly does not reduce. CT scan, you can see the pars defect there, and the slip. I think the next shot is the MRI, which shows the foraminal stenosis at 5-1, but otherwise a wide open central canal as expected.
Yeah, I mean, I think the challenge is here is trying to, figure out one, do you need to try to reduce this, number one, through some sort of interbody technique, can you reduce this, and what is the risk to the L5 nerve root, right? So she's a ballet dancer, and I understand that she wants the least amount of surgery possible, but if that least amount of surgery is a 1 level or a 2 level interbody fusion, and you give her a foot drop or a bilateral foot drop, was that worth less surgery, for that? So I think that's one thing you've got to consider when you're going to go about this. The other is trying to understand, I think, her overall balance of her pelvis and balance of her overall spine to her pelvis, in a sense that, is this something you could just fuse in situ, just put, an S1 to L5 screw with a structural allograft across there. And then, do you need to go up then one more level to perhaps L4-5, to stabilize that and hold it in place? And so I think those are the things I would be considering. Is this something that I would try to reduce back some? You can't reduce that all the way, and try to reduce the nerve root, through an interbody fusion. I still would be worried stopping at 5 and just doing a 5-1, say, T-lift, because that's a lot of shear on those screws, and will that last? I think I'd still probably consider go to 4-5, even if I'm doing a 5-1 T-lift versus, again, looking at all the films together, and is this something I could just fuse in situ, with an S1 to L5 screw, decompress the L5 nerve roots, and then maybe a 4-5 T-lift, with pedicle screws.
Would her symptoms make you choose one direction or the other if she was predominantly back pain or predominantly leg pain, at rest or not at rest? Does that affect your decision making?
Well, I mean, I still think either way you've got to decompress the nerve. I think the difference is just what are you going to do, with the spondy? Can you get it reduced and stabilized with minimal risk with just a 5-1 T-lift? Now, I guess if it's just if it looks like it's a grade 2, I guess you could probably do that and get away with it. I would just be worried with that angle and that much shear on the screws. Would my construct be stable? Would that hold? And I would be nervous about that. So I guess, all that being said, though, Mike, I think what I would try to do is I probably try to do probably try to do a T-lift at 5-1, decompress the nerve, reduce her some, right? Not reduce her, all the way back, get the nerve root decompressed, and I guess see what it looks like at that point. But I still think strongly trying to consider maybe going to 4-5 as well. I know she wants the least amount of surgery, but I'm just worried that I could hold that in place with just a 5-1 T-lift.
Is there any role for MIS in this patient?
So do you, we don't have an x-ray here, but where is her symphysis relative to the superior end plate of S1?
How old is she?
She's 71, but she's a healthy 71. And she's got good bone density. Doug, I don't know the answer to your question. I did not include that.
So, because to me, this is one where, if you project a line off of the superior end plate of S1 and it's above the symphysis, this is one where I think an ALIF and perk screws is a really good option if you can get in there. Because at worst case scenario, you might need to take a little bit of the inferior margin of L5 where it's sort of rounded over. But if you've got a trajectory off the superior end plate of S1, you do an ALIF there, you can get her reduced. You may not want to reduce her to a 0. You may want to reduce her to just a grade 1, but you can indirectly decompress the foramen and probably do a pretty good, get pretty good. The other thing, though, I would want to see, just looking at that sagittal, is I'd want to see how big I would probably get a CT to see how big her L5 pedicles are, because particularly in these people who've been there a long time, they sometimes have really tiny pedicles, and you have to go to 4 anyway just to get the fixation. But I'd lean towards an ALIF if you can get above, if that trajectory is above the symphysis.
So yeah, Doug, I was considering that too. I just didn't think with that angle, I didn't think, you know, again, don't have the films to look. I just didn't think that was an option. So
Yeah.
I wasn't even counting that. I wasn't even counting that.
Cliff, in your presentation last week, you presented a very similar case to this. What are your thoughts?
Yeah, this case to me, first of all, slip angle is negligible. This is at 7, it kind of blew me away with that age. 71, my whole brain changed because, you know, this is an arthritic type problem. This is not a deformity type problem because my first look at it at 35, 45 years old, I'd do exactly what Doug said. I'd go in, I'd nibble that thing off. The sacral slope here is not bad. So I think you could get in there and pop that open, and I would want to put perk screws in. I have to say at this age group, I would, with a disc looking that healthy, I would cringe taking that 4 or 5 disc away. So, but again, the thought of these kind of atrophic L5 pedicles would resonate with me fairly well. So, but now factor in 71, and I might just default to putting in, you know, those triangular screws, L5 screws, and then S1 into L5. I think that's very strong. The anterior column here is already kind of solid on that right image on the CT scan. So I think you could basically do an in situ, an aggressive framinotomy and put your screws in at one level. I wouldn't be as concerned, Mike, with the shear forces with that anterior column so arthritic, but that would be that's an age-related decision. Other than that, I would do exactly what Doug said.
Okay, so you do a kind of a Bowman variant S1 pedicle screws going into the L5 body?
Yeah, I don't even think I bother with the allograft across it. I think you even lag screw it. There's so much degeneration at 5'1". I think you could do aggressive framinotomy, get your nerves decompressed. And I think just the static nature of that fusion will probably do fine for this age group.
Okay. For the sake of time, we can show what I did. So I actually told her L4 to ilium was my go-to, and that's what her first opinion was. But we talked a lot about it, and she really wanted minimally invasive, and her bone density was strong enough. I kind of gave her the odds on this. We may need to come back in and revise this if it doesn't hold, because I shared all the concerns that you talked about, Mike. But I ended up doing a minimally invasive TLIF. And I'm not one of these guys who does nothing but minimally invasive. But my thought process was that if you go to the next slide, Jason, if you look at the picture on the left, you know, there's no bony connection holding that L5 to the S1 vertebrae. It's all soft tissue connection. So if I went open, I was concerned that I was gonna need a lot of metal to hold that in place or to hold things stable. So I opted to do a minimally invasive TLIF and with minimal soft tissue disruption. I got a structural allograft in there. It's not a perfect reduction, but the point of that is just to do the fastectomy for the neurodecompression, increase neuroforaminal height.
Did you stealth your screws, Mike? How'd you get your screws in?
This one, I think I used a robot. So we have a robot at my institution. Yeah,
Yeah.
Those are challenging screws. That L5 screw is kind of challenging.
Those are the hardest screws to put in, period.
Yeah, and I don't think I could have done this with an AP CR or AP view, just looking at the owl's eyes. So I had to sneak those screws in.
That would have been the advantage of doing an ALIF first, because then it brings the screw back a little bit. That looks beautiful. That really looks great.
And I'm still waiting on her. She's about 1.5 years out, and I don't know if this is fused or not, but she's back to ballet. So we'll see in years to come if
It's a win.
or not.
Win.
What's that?
It's a win.
It's a win.
I don't know. It's still early in my book. So any other critiques or comments?
73 now, Mike. She's 73.
Mike, that's a very nice job.
She's dancing.
I'm afraid to tackle cases like that with a TLIF. ALIF has been my go-to for spondies for a decade and a half at least. The one thing you made a comment about the angle of the disc for ALIF. Somebody did, I think. Mike did, but there are some companies, Nuvasive is one, that make angled instruments. They're actually designed originally for laterals, but I use them on these very high slope angle spondies, and they work wonderfully. You can get the disc cleaned out. You can get a partial reduction with these angled cobs, and then you get a little bit more direct trajectory for your inner body. So if you were ever, I mean, I know the other companies may have them, but Nuvasive definitely does. And you can use those angled instruments, and they work really, really nicely. They have angled pituitaries as well, angled curettes, all sorts of things that make a difference for when you can't actually visually see into the disc space. And it works really nicely if you really feel like you need to do an ALIF as your procedure for this.
All right,
Further
guys.
thoughts or comments?
Go ahead, Mike.
All right, I think we're over time, Jason. If
Yeah, good mix of cases, guys. That was interesting.
Yeah.
Yeah, we'll go ahead and kind of close things out, guys. First of all,
Dave Polly, by the way, he commented, and I agree with him. He is a past president of the SRS in the audience and a member of the LSRS. He commented, you got about 10 to 15 degrees of lumbosacral kyphosis reduction with that, and I think that's a very nice job, Mike. That's more easily achievable with an A-lift, but you did a nice job with a T-lift. That's fantastic.
well, I'll tell you that it wasn't really my intent. I wasn't trying to reduce. I was just trying to distract, and it just kind of turned out that way. So I wanted to put as little stress on this construct as possible. But
Take what you can get.
exactly, I took what I can get. Yeah, exactly.
all right, guys, let's go ahead and wrap things up. Mike, those were great cases. I want to thank everyone who tuned in. Really, it's been a pleasure to participate in this ICL. We've had incredible attendance over the last 3 weeks. I really want to appreciate everyone who's tuned in. A huge thank you to the faculty tonight. I specifically kind of asked this group of people because I have the utmost respect for you guys. I've learned so much from you guys over the years, and I knew you would kind of provide this sort of discussion. So I really appreciate you participating. To Jeff and Mike, who are taking over the education committee, good luck to you guys. I'll miss being part of it. A couple of quick announcements. The Lumbar Spine Research Society meeting will be virtual in April. Unfortunately, I don't think we're ready just yet to kind of be back in person, but it will be from April 8th to the 10th. So go to the website to kind of find out the details on that. Please fill out your evaluations. We obviously want to get your feedback, and you can also collect your CME that way. So thanks again, everybody, and have a great night.
Thanks, guys.
Thank you. Nice job.
All
Very
right,
fun.
good job. Thank you.
Thanks, guys.